Thank you. Yeah. So over the next 15 minutes, I'll take you through blood transfusion and volume transfusion guidelines in PPH. There are several issues in PPH, and what we will be focusing in this presentation is mainly the fluid management. Of course, there is uterotonics, which is very much in discussion, and carbitocin is a new kid on the block, which is generating a lot of CMEs all over the country, thanks to the different companies who have brought it out. But more importantly, is the focus is back on PPH, and postpartum hemorrhage is the discussion which has again come back, which is so important to keep the discussion rolling and understanding more about the subject, which we have still nowhere near to conquering, and it still leads to a lot of preventable maternal mortality and morbidity. So first thing about blood transfusion would be avoiding or minimizing a transfusion. How can we make a situation where we do not need to transfuse in the first place? Well, that is something which is the more ideal thing to do. So building up hemoglobin in the antenatal period would be the first point. So where you will be doing a complete blood count testing. I think now most of us do understand that just doing a plain hemoglobin makes no sense. So we need to do a CBC testing. And also it's important that we just don't do one in the first 3 months. We possibly repeat one later between 24 to 28 weeks or closer to delivery to understand that the hemoglobin is optimal prior to delivery. So CBC testing, at least one or more than one occasions in pregnancy, would be optimal to understand that if your oral iron is what she would be given if she's anemic, and if oral iron does not work or there is a problem in compliance, then there is always an option to consider parenteral iron in any point of pregnancy to make sure that she's got sufficient iron stores and not anemic prior to the delivery. And then there's prophylactic uterotonics at the time of delivery. At the anterior shoulder, we do use tranexamic acid, which has got some evidence to suggest of benefit. The AMTCL principles have to be followed, active management of the third stage of labor, and the use of PGE1, PGF2 alpha appropriately as a prophylaxis before the actual bleeding and before the actual event takes place are some of the other ways in which we can try to minimize the risk of heavy blood loss and subsequently transfusion. Then if there is blood loss going on, there are mechanical methods to minimize it: bimanual compression of the uterus, aortic compression, which again is a skill to know about it, but again, that's all there. And those are things which can minimize the blood loss in a moment of acute event to either avoid the transfusion or minimize the need for a transfusion. So anticipating PPH and preparing for the transfusion it should have a clear protocol. And as a lot of protocols in labor room should not be restricted to a labor room manual or in a book. It should be put up on the wall, ideally. So all the new registrars or the new doctors who are working there, and also the other medical staff, the non-doctors, the paraclinical staff who do most of the deliveries would know exactly what to do in a situation where there is heavy bleeding coming up out of the blue, or even anticipated what exactly the moves or the initial maneuvers should be, how exactly to tackle it. So skill drills, we do mention about it, and I'm not sure how many medical colleges generally over the country do it, but this is something which is a must in any busy labor ward, because it will help in delivering the best outcome when there is a true emergency. So skill drills are learned from the Army and from the Air Force, and from generally that is where it's come to, but it's in labor ward. It's so important that we know exactly what to do, and when there's a time of emergency and things are in place. Blood bank in sight or near with immediate access. So we talk about whenever there's a delivery or a high risk delivery, definitely there should be a blood bank nearby. So in case we have a patient who is high risk or has a chance where you realize antepartum that she can bleed heavily during intrapartum or immediate postpartum, you would like to refer her to a tertiary care center. And when you talk about tertiary care centers, one of the things which is a very important requirement there is the presence of blood and a blood bank where you can get blood products at a very short notice. Group and screen sample and cross-match in advance. So these are some things which we do. Generally, we see you can't keep cross-match blood for more than 3 days, but at the same time, you do sometimes keep things ready. When you're doing something like an adherent placenta, where you know that there will be very excessive bleeding, a complete placenta previa section, or when you're doing know that there'll be excessive bleeding, these are times when obviously you will keep some blood ready or keep some cross-matched ready in the blood. So massive blood transfusion will be defined as the replacement of transfusion of more than 50% of a patient's blood volume in 12 to 24 hours. It is associated with hemostatic and metabolic complications, and several issues are there in blood transfusion, mainly the volume status, the tissue oxygenation, which is a very integral part why blood products need to come in early. You just cannot manage with crystalloids and colloids because they will give you your volume, but they won't give your tissue oxygenation. So that is so important. Management of bleeding and coagulation abnormalities. So as the correction takes place, the bleeding also has to take place. Unless the tap is closed, the tank will not be full. So the tap, if it's still open, if she still continues to have bleeding, then you really have to continue giving your correction of the fluids or of the volume replacement. At the same time, ionized calcium, potassium, and acid-base balance. So there's some of the considerations we have to keep in mind when you're having massive blood transfusion. And of course, the big elephant in the room is coagulopathy, which we will be taking later in this presentation. So what would be the initial moves when there is massive blood loss? Here we are talking about PPH, but you know that blood loss can happen in any situation in an obstetric patient. And the first initial moves should be to get some wide bore peripheral IV lines on both arms. And just talking about that, characteristically or maybe lackadaisically, we do not have wide bore IV lines, but we normally do an IV when a woman is undergoing a section or even for a delivery or when you're inducing her. So I think it's a very important to use wide bore peripheral IV line, even if you're putting one line, to make a reasonable caliber of the IV catheter, so that in case that there is a situation which arises, you can infuse fluids fast. And in case it's a massive blood loss, you must have two arms, because it will be important that when you give blood products, it invariably goes slowly. The other side you can use for your crystalloids and colloids. Urinary catheter for hourly output. I think that's again an important thing. So one important aspect would be to know your intake output chart. And so for intake output, you put a urinary catheter where you can check hourly urine output, which would give you a very good idea about how things are going and how much of replacement needs to be done. Baseline CBC, PT, APTT, fibrinogen, and D-dimer. We know once the fluid goes in, and once it goes in very fast, blood gets diluted, and all the values will come as altered, or all the values will be incorrect. So one of the best things is when you're starting a wide bore IV line on the other arm, not the arm which already has a line possibly, then you just at that time you collect blood for all these things. So this is the basic thing which we used to do in medical colleges. So when you're starting the IV, first time when you do your IV, collect the blood, send it for the baseline tests, and then start your infusions, maybe crystalloids on both hands, and then till the blood arrives. Blood and blood product requisitions, see how much you need. Possibly, I think it's a good idea to always request for more, because most of the blood banks, as we understand, may not give you, when you ask 4, they may give you 2. You may ask for 6, they may give you 4. So I think it may be good to ask for more, and rather than ask for less, because you need to keep on repeatedly asking if that is the case. So initial fluid resuscitation would generally be with crystalloids. That's what we have been taught, I think, maybe 20, 25, 30 years ago, and things haven't changed since. So crystalloids would be the first line of fluid replacement when there is a heavy blood loss of any kind, especially with PPH. There's some guidelines to show that not to exceed 3.5 liters, that's 7 in a row, and generally to warm the fluid may be a good idea rather than to give it cold, because that will help in preventing hypothermia. Yes, we can use normal saline, ringer solution, ringer lactate, and those would be the commonly ones which we start with. It does not alter hemostasis or renal function, so that is good. Only 25% of the infused fluid remains within the intravascular compartment. And the warning which goes out when you're giving very fast volume replacement with crystalloids is dilutional coagulopathy, especially if the bleeding also is continuing on the other side. Coming to colloids, where it has a greater impact on intravascular volume, but there are problems in inhibiting platelet aggregation and interfering with fibrinogen level measurements. And we'll come to that a little later in the presentation, that fibrinogen level measurements seem to be a very important point, because the other ones, PT and APTT, may not give you a very clear result once they are deranged or once there are more problems. So hydroxyethyl starches of 6% is one which is most commonly used, and we'll stick to that. It's a 6 to 8 hour half-life and a greater expansive capacity of 80 to 120%. So blood product transfusion, when will you be shifting to blood? When will you say that crystalloids and colloids are not enough and I need to get blood products in the picture? I think that there's no firm criteria or guidelines present, and it will depend essentially on the clinical picture and the hematological parameters. So if she's already anemic, or there's a baseline anemia which we have either not been able to correct in the antenatal period, and she comes into the labor ward and she has blood loss, then obviously you need to act more urgently. Then the other thing which we always also sometimes overlook, but we cannot, is the weight of the patient and the build of the patient, which is so important to get an idea about how much liters of blood she would normally have, and then the consequence of a fraction of that, how much that would make a difference in that blood loss. The other important problem which we have, and which we thank Dr. Sheila Mane, I think we'll be speaking a little later, and a lot of her classes and workshops which she does on PPH, about the assessment of blood loss. And that is something I think which we should again go back to our study books and go back to our tables, and we should be attending more of those skill workshops on PPH to really know the assessment of blood loss, which will give a good idea, because we grossly underestimate when we go by only the visual estimate. So it need to be a little bit more objective than that, and that's something that's a different discussion. Valid consent to be obtained before blood product transfusion. Retrospective of consent may be taken in emergency. Always, you don't need to rush, because if it's a acute event where there are 5 people in the labor room, everybody will be busy doing something else, and the person going to take a consent would be missing out on one of the important things to be done. So if it's an emergency where there's everybody's running around in the labor room, then of course you can take it retrospectively, but otherwise you can take a valid consent that blood products are being given. The debate about blood and blood products, I think, is not there anymore. I think all of us are very well understood that now you don't get almost fresh blood. Most of the time you get blood products, and that is the way forward, that blood products need to be given of different form. We'll come to our different blood products in a minute. So fresh frozen plasma, if that is what we are transfusing, it should be at the rate of 12 to 15 ml per kg, should be administered for every 6 units of red cells during major obstetric hemorrhage. So if she is a weight of 60 kg, then you would be giving 720 to 900 ml of FFP. It depends on how much it comes for. Then you need to thaw it, and then you need to use it for every 6 units of red cell during major obstetric hemorrhage. This is coming from the RCOG 2015 guidelines on blood transfusion. Subsequent FFP used to be guided by PT-APTT tests to results, so they're less than 1.5 times normal. Then cryoprecipitate to be used to keep the fibrinogens left to more than 1.5. Cryoprecipitate may not always be available, but that is something which would be required in this case. And platelet transfusion to keep platelets above 50,000 per milliliter in acutely bleeding patient. So obstetric hemorrhage and transfusion, based upon population-wide data from developed countries, the rate of transfusion in obstetrics is relatively low, 0.9 to 2.3%. In some situations, patients with life-threatening hemorrhage can require large volumes of blood products, which we can call massive transfusion during maternal resuscitation, and that would be something which we would be aware of. So massive transfusion would be 10 or more units of red blood cells, occurring rarely in obstetrics, 6 out of every 10,000 deliveries. Among patients who receive massive transfusion, abnormal placentation seems to be the most common etiology, seen in 27% of cases. And then this is one massive transfusion protocol which is there, which we thought we'll share here in this presentation. So sometimes it becomes very difficult to ask for how many FFPs, how many packed cells, how many platelets, whether you need cryo. And so you sometimes, if you ask for one Instead of asking for different things, you ask for a massive transfusion protocol package, and then they give you a package of everything together. So we'll just come to that in the next slide. It's a process of obtaining blood products for emergent transfusion in the management of severe unanticipated obstetric hemorrhage that is logistically challenging and time consuming. So MTP, that's massive transfusion protocol, has been advocated as an essential tool for facilitating early transfusion of sufficient volume and types of blood products for patients with massive obstetric hemorrhage. So what does it comprise of? So it's like a package, as I said. So it comes with 6 O negative uncross-matched blood products, 4 units of AB plasma or thawed group A plasma, and 1 apheresis platelet unit, that is 6 units of pooled random donor platelets. So it's like a package, and it comes to you, and this is what you use together in any patient as soon as when the situation arises. So plasma and platelets are important in correction of coagulopathy and thrombocytopenia that occur in obstetric hemorrhage, which we know. Again, it may not be available in every blood bank, or it's not something, a concept which a lot of us have in India possibly at this time. But massive transfusion protocol is one way of making sure that a package of blood products reaches the patient early and is started early. Again, it may be used a lot of times in trauma settings, and sometimes in obstetric settings. So this is the slide to screenshot. Packed red blood cells, which we concentrate to RBCs, increase the oxygen carrying capacity and the delivery of oxygen to the tissues. We said that because when you are massively losing blood, there are 2 issues. One is volume replacement, and one is the oxygen carrying capacity replacement. So there are 300 ml per unit, and 1 unit increases the hemoglobin roughly by 1 gram per cent and the hematocrit by 3 to 4%. If there's FFPs, there are plasma proteins and clotting factors. It's used to correct the coagulopathy. 250 ml is there in every unit. It comes like those yellow units which are frozen, and then you need to thaw it. And 1 unit will increase fibrogen level by 7 to 10 mg per dl, and most clotting factors by 5 to 7%. Then platelets, we said, want to keep the platelets above 50,000. Sometimes, many times you may not need platelets, but of course, if you check and you have a low platelet count, then definitely you'd like to give it. And 150 ml is there in a unit, and 1 unit increases the platelet count by 25 to 30,000. Cryoprecipitates have some clotting factors: fibrinogen factor 5, 8, 13, and von Willebrand factor. It's used separately in the treatment of hemophilia A, von Willebrand disease, and fibrinogen deficiency. And here it's mainly for the fibrinogen deficiency, which is also a part of this spectrum. And 40 ml is there in a unit, and 1 unit increases fibrinogen by 10 to 15. And the other modality which we mentioned is recombinant human coagulation factor 7A. It promotes coagulation cascade off-label adjunct therapy. Again, a lot of heard in anecdotal situations more than as a regular use. So coming a little bit to the other part of PPH is coagulopathy, and that is one of the killers also. So one of the killers is the loss of blood, the loss of oxygen carrying capacity, the volume reduction. Along with that, there's another problem, which is the coagulopathy in PPH. And it happens due to the loss, the dilution, and the consumption of platelets and clotting factors. The best way to monitor for coagulopathy is not very clear, but it is generally thought that fibrinogen levels would be possibly better than PT and APTT, which we do because they are more specific. Then there is a issue on coagulopathy about detecting it, because by the time it is clinically detected, all the time it's quite too late. But you can suspect it, and you can always try to correct it very early. But there is one important issue of coagulopathy is whether we can have some on-site monitoring to find out whether the coagulopathy is setting in. And this will also guide us to what products to use. And in this perspective, we have this viscoelastic testing, something which has come up recently, which is coagulation status at the point of care. So initially, we used to have that clot formation test and the bedside clotting test. This is a little bit more of a commercial version, or a little bit more of a graphical version of the same. It's a commercially available point of care tests that use a sample of blood, patient's blood, to derive various parameters pertaining to the quality of clot formed. There's an analyzer which imitates sluggish venous blood flow, and derives measurements of the kinetics of each stage of clot initiation, strength, and lysis. So how is it done? You take a sample of the patient's blood, you put it in a cup, and there's a sensor rod inserted into the blood sample, and then either the cup.
Dr. Basab,
yeah,
sorry to interrupt. Maybe a couple of minutes.
Okay, fair enough. I'll speed it up. Thank you, Dr. Rajshekar. I'll speed it up. We'll just have a few more points to go, and then we'll finish. So either the cup or the rod is gently rotated, and then the clot is formed. And then basically, we'll just run through it. There are two of the tests which have stood the test of time: the thromboelastography and the rotation thromboelastometry. And this is how they look. So this is how a graph normally looks. And this is the different graphs which may be there at different situations, which can be interpreted likewise, and you will know what exactly to do. So I'll skip this part. We'll go to the last couple of slides. How can you avoid banked blood? Well, there was a thought once upon a time that before delivery, you give your own blood, keep it in the bank, and then you use it again during the delivery. That's not recommended anymore. And the other interesting thing is intraoperative cell salvage, where you use the blood which you're losing on the table, and that is recycling and coming back into you. So this is usually looked when more than 20% of the estimated blood volume is expected to be lost. A multidisciplinary team is there. If you have an anti-D factors, if it's an Rh negative woman, and it may be considered. So the last slide, severe PPH is rare, but its incidence is increasing. We have another few interesting talks on PPH later in this session, which I look forward to hear. Evidence suggests that IV use of crystalloids should be limited to treatment of mild to moderate hemorrhage and blood products when it is severe. But it's sometimes very subtle. The line is when it becomes from mild to when it becomes severe. But at the same time, that's what is the recommended thing. And the standardized massive transfusion protocol relies on interprofessional team-based approach, as for so many things in obstetrics, to minimize maternal morbidity and mortality. Thank you very much. Thank you, Dr. Rajshekar. Thank you, POGS, for inviting me for this. Thank you.
Thank you, Dr. Basab, for that excellent presentation. There are no questions in the chat box, but I would like to ask you one thing. All of us are quite fortunate that we are working in larger institutions where we have gotten access to blood products. But the majority of deaths are happening in peripheral hospitals. They do have access only to whole blood. Okay, that's a reality. So what precautions do you advise in such situations? For example, administration of calcium and all those things.
Yeah. So I think so. Again, if you can anticipate the situation you can have where you can have massive PPH or PPH, that would be the best, as we have already said. Often you can't do it. In that case, you have to rush in a hurry. So any obstetric unit should have some sort of a link, I said, with the hematology unit nearby with the blood bank, because they cannot make them. You could be your good friends. So suddenly, if there's a problem, yes, you get, if you get whole blood, whatever you get, we will be using. Of course, there's a chance of overload, which is something which we have to be careful about. So you will be giving them diuretics so that you don't overload the system. Also, as you said, that calcium is one of the things which you will be aware. Citrate will be there in whole blood. So those citrate toxicity, those are other issues which you will keep in mind. Checking the pH, acid-base balance. This will also be if you have an intensivist or if you have a medicine specialist, he or she would definitely come into the picture to work on those things. Electrolyte imbalance, all those things also have to be kept in mind.
Thank you, Dr. Basab. I think it's time to go on to the next presentation. Over to Dr. Shashi.